Thank you very much for attending the first panel this morning and staying around for this next panel. I think we've got a couple more panels today that you're going to find to be very enlightening and very informing to the entire process. I want to talk to you a little bit today about modernizing Florida's healthcare delivery system, and that's kind of a broad topic, but I want to frame it like this, and I want you to think about things for just a moment. How many of you live along the coast of Florida? Raise your hands. It wasn't a trick question for those of you. Along the coastal communities of Florida. So that's a fair amount of you. And I'm going to bet that some of the things I'm going to tell you might surprise you a little bit. We really have two states. Now, there's plenty of people that live along the coast, and they've got great access, they've got great quality of care, they've got a tremendous amount of providers and specialists. And then there's the rest of Florida. And we have counties that don't have dentists. We have 33 counties without ophthalmologists. We have 8 counties in this state without a hospital. And so the paradigm that you live in along the coast is radically different than the paradigm for a lot of other Floridians. And so we really truly have two states. Now, I represent a very urbanized area in the community of Naples, where we're blessed to have a number of different hospitals and great quality of care and tremendous providers. But I also represent the community of Hendry County, where there's one hospital on the complete opposite side of the county that's not convenient to anyone having an emergency. And they have a disparaging lack of resources. We have some counties where the only form of health care is the county health department or an FQHC. And so I want you to think about, when we talk about affordability, when we talk about access, that you got to step outside your paradigm a little bit and think about the people in the rest of the state. Because what does access mean to that person and affordability mean to that person when there are no providers? What are you going to do? How are you going to take care of that? And so the discussion today in this panel will address how we can do better outreach and access and leveraging technology to do that. And so today, I'd like to introduce my panel. I'm thrilled to death to have this group on stage with me. They're certainly going to know more about the topic than I am, and I want to make sure that I learn from them. First off, we have Mr. Chris Day. We then have Mr. Josue Rodas, Dr. Gita Nair, and Mr. David Young. They're going to share with you from their industry perspectives and from their personal perspectives exactly how we can go about the process of addressing the challenges, looking at our opportunities, and coming up with solutions that can be shared with policymakers. But to kick things off, I would like Mr. Rodas to share some of his thoughts that he's put together on a bit of a PowerPoint that will just kind of frame the conversation a little bit more. Josue, if you would, please.
Thank you. Good morning, everyone. I'm Josue Rodas. I'm with the University of Central Florida College of Medicine. I'm directing the Regional Extension Center activities. And what I wanted to share with you over the next few slides is just to set the context for the panel conversation this morning, some of the activities that are going on currently and moving into the future. As you have probably seen in the last few years, there has been a recent acceleration in the health information technology movement. These efforts go back to, as a catalyst for this transformation, goes back to 2009 when President Obama signed the American Recovery and Reinvestment Act. HITECH, which is a health information technology for economic and clinical health, is part of the legislation and is designed to encourage physicians and healthcare organizations to adopt and implement and use medical records technology meaningfully. Under the HITECH Act, there are several key programs like Medicare and Medicaid incentives and regional extension centers that have been established to help physicians with these efforts. Together, these programs build a foundation for every American to benefit from EHR and health information exchanges as part of a modernized, interconnected, and vastly improved healthcare system where healthcare providers have information at their fingertips to provide quality, efficient, and cost-effective healthcare to their patients. There are 62 regional extension centers like the one I represent in the nation. There are 4 here in Florida, including the one at the UCF in Central Florida. Through federal funding, these regional extension centers are helping physicians through the adoption and implementation of EHR systems, and also to use the same meaningfully. It isn't good to have an EHR system in place if it is not being utilized to its maximum capacity and meaningfully. I wanted to share with you some of the national adoption rates, just to give you a flavor of what's happening here with this movement. Despite many of the challenges that you will see in the graph, despite many of the challenges affecting rural communities, they have actually been doing a really nice job catching up with the rest of the medical community as far as implementing EHRs. The issues that we are facing there is that there are a number of reasons why rural-based healthcare providers are not utilizing those systems to their maximum potential. Just to give you a flavor of some of the milestones at a national level is that RSCs had a collective target nationally of signing up and getting 100,000 providers to implement EHRs and achieve meaningful use. Up to last month, we have met the target of signing up those providers. The good news also is that over 100,000 of those same providers have actually implemented EHR systems in their offices. We are looking at almost 40,000 of those same providers who have attested, who have met the core measures for attesting to meaningful use. That is powerful. The target for the end of this year is that we'll have 85% of these same providers attesting to meaningful use at a national level. Locally, I can share with you that in Central Florida, we have met 100% of the target of signing up providers for EHR implementations. We are about 70%. I'm sorry, we have our goal for May of this year is to have 100% of the providers implementing EHRs in their offices. And by the end of this year, we will have 85% of our provider base attesting to meaningful use as well, or at least meeting the core measures for attestation. Just to give you a quick taste here, and this really touches on the rural providers as well, is that these efforts for the health information technology deployment, implementation, and EHRs began with the federal funding helping us help physicians who could not do this on their own. We are getting a number of calls from specialty providers right now wanting to be part of this movement as well, including those in rural communities. Just wanted to share with you the financial impact of these programs. Nationally, Medicare and Medicaid payments are estimated to exceed $10.3 billion as incentive payments for providers participating in these programs. In Florida, Medicaid alone paid over $200 million to eligible providers and hospitals thus far. In Central Florida, as you can see on the screen, last year alone, providers who are participating with the REC efforts have gotten paid over $8 million in incentive payments. And this year alone, we're estimating over $11 million in additional payments to be given to them. As we look into the future, we ask providers, are you going to continue to be part of this movement of health information exchange implementation and efforts? And as you can see on the screen, and this is very helpful for this panel discussion, I believe, because it sets the tone for what physicians want to do. Whether they have the capabilities to do that and their limitations is a different story. But 72% of the doctors are saying to us, yes, we absolutely want to be part of this movement moving forward. So just to wrap up, as we move into the future, we recognize that the overall goals for improving patient safety and outcomes and easing the administrative burden and containing costs, it means that we have to embrace the full capabilities of health information technology. We at the UCF Regional Extension Center are fully committed to that. And I haven't shared this with you yet, but just this week alone, the state of Florida granted the UCF REC a license that would allow our HIE to connect with the state HIE in the future. So I wanted to share that with you this morning just to set the context for our conversation. I thank you for your attention.
Thank you very much. That was very informative, and I think helps to do a couple of things. Number one, it frames our conversation for the massive importance of health information technology in this industry, but also with some of those charts and graphs and, I don't know, flow charts, if you will, it also helps to illustrate the complexity of the situation that we're facing. Next up, I'd like to ask each one of the panelists from your own individual take, from your perspective, or the industry segment that you represent, what you see to be, say, the two biggest challenges going forward in our industry. And to start off, Chris Day, who is with Aetna, the floor is yours, my friend.
Thanks. The two biggest challenges. So to be brief, I think the first challenge is that as we look at opportunities and the challenges that we have, we need to be careful so that we don't squeeze one end of the balloon and create an issue at the other end. So technology is an enabler, but it's not the answer. And it can actually be a disabler if you spend too much money buying technology that you can't implement and use effectively. I think it is the same for insurance reform or payment reform. We need to create effective incentives for incenting the right behavior for patients, for members, for individuals and communities, and at the same time balancing the ability for physicians to make better decisions as well as individuals to make better healthcare decisions about their own health and their family's health. So I think first is technology is an enabler, but we need to link that with business models, insurance and plan design that create more economic value around improving quality and lowering cost in the community. I think the second is, and you pointed this out earlier, Representative, which was that we have a difference. You have really in this state 2 states. You have, and so you need to focus on strategies that enable us to have a consistent feel across the state to solutions that can support the variation that exists at the local level. So a statewide flavor that can consistently be applied to meet the needs of the local community. And so that means access to information statewide, but that there is innovation opportunities for the federally qualified health centers to work in partnership with local providers, but then also to reach into the urban environment and access some of the greater specialty care that's required so that you can start to balance and access truly what's available Florida, statewide, not simply in the local community, and technology is a great enabler of that when incentivized appropriately.
Okay, thank you. Well said. Josue Rodas, if you would like to share with us what you see to be the two biggest challenges facing us in this area.
You know, I really wish I could say, you know, we can lump all of these challenges into two. There are really tons of them.
That's why there's 4.
So I'm gonna try to wrap them up as the best I can. You know, from the health information technology standpoint, what I see it is you know, especially providers in rural communities are facing tremendous challenges in the adoption. I think that the regional extension centers are making a difference, providing the extra arms and legs that they need, and the knowledge that they need to do this. But clearly, there are a number of challenges. Staff and clinician shortage being one of those. We run into situations where physician practices and their staff in some of the rural communities don't even know the basics of utilizing computer systems. There are tremendous financial constraints that we are seeing also that these providers are facing. And also just the lack of adequate and reliable connectivity is also one of the challenges that we face. We have done the best we can until now to help providers address those issues, but there's no silver bullet that's going to fix this. It's going to take a collective effort amongst all of stakeholders and organizations that are involved in improving the health care quality for our communities to be part of this. So I'll share with you as we continue the discussion some of the specific activities that we are taking to help with those efforts.
Thank you very much. Next up, Dr. Geeta Nair, who is with AT&T. If you would identify what you perceive to be two of the biggest challenges facing this issue.
Sure. So first, good morning, and thank you so much for the opportunity to be here. Really appreciate everyone's time in looking at some of the issues that not only the state faces, but the country faces. You know, my role is as the Chief Medical Information Officer for AT&T, but I'm also a practicing physician. I'm a rheumatologist seeing a lot of patients with chronic diseases. And I would say if I had to pick two, since Representative Hudson has asked me to only pick two.
Again, that's why there's 4 of you. We'll get 8 that way.
You know, I think that my view is really, again, as someone who's on the front lines of healthcare delivery and as well as a believer of health technology. And the bottom line is that we have an aging population, a population of patients who are facing chronic diseases that require high touch, High points of access are needed, whether it's for medication, whether it's for education, whether it's, just to ask questions, frankly. Diabetes, hypertension, heart failure, these are complicated diseases. And when someone sees, a rheumatologist like myself, it takes time to get an appointment. It takes time to find a rheumatologist within your zip code. And then it takes time to find transportation. It takes finances to get there. It takes, a variety of social skills and language necessities in order to find your way to my office or someone like me. And so I won't go on and on. I was only supposed to pick two. But just at a high level, we need access. Patients need access to doctors, and we need more doctors, we need more nurses. And I think the question becomes, are we ever going to have enough doctors and nurses? And the answer is probably no, which is why we need to think about strategies and technologies such as telehealth, remote patient monitoring, and other solutions out there that really improve access to care for patients who need it. And that's really it in a nutshell. That was as quick as I could do it.
Not bad, not bad. You skipped ahead to the solution part on me a little bit, but that's all right. That's okay. Next up, we have Mr. David Young, and he is with the Telepsych division of Optum Health. And David, the floor is yours.
Thank you, Mr. Chairman. Just two problems, right?
Just two problems, right.
Okay.
We'll worry about world peace and solving that later. Let's worry about this now.
Well, as the Vice President of Telepsych Services, one of the things that we do is we actually deliver psychiatric care through technology, through video primarily, real time. And if you talk about two specific problems that we have, the first one would be acceptance. Just generally the acceptance of telemedicine. We still, in 2013, run into odd resistance about the acceptance of telemedicine in terms of its security, HIPAA compliance. Is it really effective as a way to care for patients? We hear that all the time. The second issue that comes up for us is in the general area of law, rule, and regulation. When you work across the country, remember, if you see one Medicaid plan, you see one Medicaid plan. And so even though 35 states have adopted it through Medicaid, each one varies so much that it's very difficult to do an implementation that looks like the last one. And on top of that, you can have other regulations, state medical boards, state nursing boards, that also affect that. And we see that in a pretty big scale as we go across the country. So getting it accepted and then getting some rule that would make it much easier to implement for the consumer would be two of the big challenges that we have.
Very good. And I will tell you, you mentioned the acceptance piece. It's interesting. I'm pretty sure, and I don't want to go out on a limb here, but I'm pretty sure that this whole internet thing is not a fad. It's going to stick. We probably ought to look at maybe embracing that a little bit more. So we've heard from each one of them a couple of different challenges that are out there in the industry and are out there in the marketplace and are out there in our communities. All challenges create opportunities. And they create opportunities, and then hopefully we find solutions from there. So if you would, each one of you, and this time we'll go in reverse order. Didn't tell you that originally, sorry. And identify what you see as your biggest opportunity that you could bring to the state of Florida.
Other than my appearance here.
Other than your appearance here, which we are all very grateful for, obviously.
Well, one of the things, of course, is we talk about the two states of Florida. Many states are like that. I'm from Texas, in case you were wondering where that accent is from. And Texas is not only two states, but it seems like multiple countries in the way, and it's so large and regionalization like that. And so one of the great opportunities is to provide not only care to those areas that are having trouble with access. And we bring up the access. I'm sure most folks know that only 4% of medical students now go into psychiatric residencies. And since 50% of them are over 55 years old, that means in 10 years we're going to have an absolute crisis in psychiatry here in the United States. So we can bring that maldistribution of psychiatric resources as a specific example to those communities in Florida that need them, that also provides consistency and continuity of care from the rural to the urban. And so that those urban specialists can communicate with the rural primary care providers and pharmacy providers, nursing, and provide an overall consistent health care plan for the state of Florida. I think that's the greatest opportunity.
Excellent. Thank you, David. Dr. Nair, same question.
Sure. So, again, I think the greatest opportunity is really to think about where we are in other industries, whether we're looking at the airline industry. Somehow it is easier to make a reservation for a flight using this device or this device, or to check my bank account information using any one of different technologies out there. But to find the closest doctor to me, to make an appointment, to find out my own blood work and status of my own health account, not so easy to do. And so I think the bottom line is the opportunity we have in healthcare is to look at other industries, see what some other industries have done to transform their problems, because I think we all understand that everyone's being asked to do more with less across the country and across the globe. And so the opportunity really is to think about the paradigm of healthcare and flip it on its head, right? And say that why can I only see a doctor within the constraints of the four walls of an office or the four walls of a hospital? Why can't I do it from home? Why can't I do it from the closest primary care doctor that I have and then remote into a specialist if needed? So I think it's about really just shifting the paradigm and really thinking of healthcare not within healthcare, but actually outside of healthcare.
I concur completely. Mr. Rodas?
I think from the efforts that I lead with the regional extension centers, I think the two greatest opportunities include continuing to promote the adoption of electronic health record technology and health information technology in general, with the understanding that those efforts are going to lead right into health information exchanges. I think it is a must-do. I think it should become the backbone of our healthcare system in the future because it really addresses a lot of the concerns that we are seeing. I'm a former practice administrator. I've worked with hospitals nationally, and the common denominator that I see working within hospital institutions and also some of the clinics that I work with is the inefficiencies that exist in the way we handle our day-to-day business. So when we start looking at Dr. Nair's concerns, for example, involving the lack of capacity to absorb additional patients, etc., we have to address those inefficiencies that exist within our own healthcare facilities before we can begin to evolve into improving our healthcare system in general. So I think that's just a side comment that I wanted to make. But I also think that the second opportunity for us right now is to educate. There are so many providers and practitioners and staff members in physician practice that I talk to that are just don't really get it yet. So we have to, as it relates to what it really means to embrace health information technology and informatics. So I think it's going to be critical for us to educate. I also think that, especially in some of the rural settings that we work with, is that some of the academic institutions that are educating clinicians, nurses, medical assistants should incorporate some sort of health information technology curriculum as part of their training program. So I think education and promotion of these programs, I think, is what would help, at least from the angle that I see that right now.
Thank you very much. Christe, what do you say?
Collaboration. I think not the high-level collaboration of it's nice to sit at the table and talk with everyone about ideas, but we need to get better at maximizing the efficient use of healthcare and public health resources to manage communities that we have. And I just go back to some of my training. I started working in hospital operations, and then I worked in health policy, and then moved into managed care and sort of the business side. And we're trained in silos, we work in silos, but our communities live together. And the challenges that we have, we need to move from working on managing patients to populations. We need to align our infrastructure, our informatic and technology capabilities to support the needs of those communities. We need to have the help and assistance of health plans who can create competitive product and plan designs priced so we can have affordable access to health care that is connected, so that we do have a different experience, not only interacting with the health plan, but the health plan is now actually working with and supporting providers, and that providers are actually providing physician-directed care versus health plan-directed care and physician-directed care and federally qualified health center-directed care, that we're coming together and you have essentially the captain of the ship being a physician supported by a care team and technology to manage the populations that we serve better. And I think that's a real opportunity for us to collaborate for us to lower overall costs that we're each spending independently, and for us to really address quality and cost and health outcomes issues that we have in communities in Florida and broader today.
Well, I can tell you that the healthcare industry is not unique in their silo mentality. Interesting thing happens when you get elected and you start to take a look around the people you're going to suddenly be working with in the government, and you realize that really no one ever talks to each other. And it's very odd in that regard. And so I certainly get what you're saying, and it's certainly been kind of a quest for me in my time in office to build on some of those collaborations and create some better efficiencies. I heard you say a few other things that just kind of going to take me off script just a moment, but one of you mentioned talking about leveraging technology on your iPad and your iPhone and all those types of things, that we can pay our mortgage online, and that's secure. We can do all of our banking online. You can trade stocks online through your individual accounts and all the security there, and yet somehow we don't seem to want to embrace that in the healthcare world. I'm curious to know, do you think that is a function of educating the masses, or do you think that is a function of us maybe changing our curriculum in medical schools or with our providers to be able to get those folks more accustomed to it so that they can explain it to their patients? Doctor, maybe for you.
Sure. So since I'm the one with all the devices on the table here, I actually think that we are, Representative Hudson. I mean, again, I practice today. I work with doctors in training, medical students, residents, et cetera, and they often come to the clinic with just this and a stethoscope maybe. But they don't have their pockets full of books the way I used to do when I was in training, and they're just like, oh, Dr. Nair, you can just do this and you can just do that, and 5 seconds, it's all done. And so I actually do think that we have this perfect storm of consumers who are saying, hey, I use my device for everything else, or I use technology for every other industry, why not for healthcare? We have doctors or doctors in training who, are growing up with these technologies, Facebook, Twitter, social media, and they're saying, hey, there's so many efficient ways to communicate, so why wouldn't I also incorporate this into my practice? And we have policymakers such as yourself and some of the policies that Jose mentioned in terms of, hey, policymakers are saying the costs are unsustainable. How are we going to do this? And not that technology is going to be the silver bullet, but that it really will be this enabler of a pathway to a better healthcare system. So I think you have the policy shift happening. I think you have consumers. I think you have docs. But I think just like any other industry, it takes time. I mean, banking certainly didn't change overnight. And 20, 30 years ago, we couldn't do what you just said. And it's really only now that we're also even seeing innovation in banking with regards to, cashing a check on a mobile device or a smartphone. But before, just to get online was like revolutionary. And I think healthcare is just trying to get online right now. But I think that the opportunity is the innovation and to say, look, let's push that paradigm. Let's move this into a way that actually works for a physician and a patient so that it actually improves care instead of impeding care with clunky devices or clunky technologies that don't make sense in healthcare.
Okay. Anyone else want to weigh in on that? Sure, go right ahead.
I brought up that medical education, too. One of the things that we find in a direct real-world application when we're out here is more resistance from the professional part of our system than the consumer. When I first got into this, I was told that autistic kids would not work well with video. They work absolutely beautifully with it. They were great with it. And so later I started doing child and adolescents, and they told me, no, adolescents with their mindset all will not work well with video. It was wonderful. It was beautiful. They responded to it, and as they do with text messaging. And then when we got into long-term care and telepsychiatry, well, of course, Aunt Mildred is not going to want to do this. And yet we find that she readily adapts, and so grateful to be able to see her psychiatrist face-to-face and take time and et cetera. So we find that there are conventional thinking about the delivery of healthcare through technology that comes more from the professionals that's restrictive than from the consumer themselves, who are readily adapting all the technology that you see out there. So I think if we could get to the medical schools, the nursing schools, the pharmacy schools very early with the technology and using the technology in a very aggressive way in treatment, we could probably move that resistance down the road quite a bit.
Okay. Anybody else want to weigh in on that? Chris?
I would only say that I think we have a challenge. I'm less worried about the way that we're trained as much today. I think that we've moved from each of us working in silos to thinking about interdisciplinary care and starting to work as a team. And so I'm a little less worried about the sort of the future. I'm more worried about some of the current challenges that we have evolving a system who hasn't really either embraced some of the technologies yet, or in the twilight of the career, the last 10 years or so of a physician's practicing life, whether they're going to be positioned and interested in making the changes now or kind of ride it into the sunset. But I think the key thing is meeting people where they are. We have a lot of technology, and it's really understanding and breaking down what do we traditionally think about how people interact with technology in their environment. And one of the things that's always a common misconception is that seniors, for example, don't use technology. So all this stuff, they don't use it. And in fact, seniors are often the most motivated and highest users of at least Aetna's technology because they want to live long, healthy lives. They want to see their grandkids grow up. And so they're really highly motivated to use the things to maintain their health. And so it's really thinking about what do consumers really want, and then how do you take the technology that they need and then tailor that to their specific needs.
Well, and I agree on the senior assessment. I know my parents who are retired, they Skype with my kids all the time, and are always connecting. And dear Lord, my dad sends me a lot of email. So let's shift now. We've addressed challenges, we've addressed opportunities, and I will tell you that my role in the legislature is to deal with the budgetary issues surrounding healthcare in the House. And to me, every taxpayer in Florida should be treated the same. That hard-earned dollar that they send to the state of Florida to be spent on their behalf for their state and their services is no different if it comes from Hendry County or if it comes from Palm Beach County. And as far as I'm concerned, we need to make sure that we are making sure that we're treating all Floridians in the same manner. And so if you could, and I know that some of my colleagues are in the room, other legislators in both the House and Senate, if you could, if you had all of our ears at one time, and while there is no magic bullet, let me know what it is you believe is the best solution within what you've talked about within your challenges and opportunities that we could move forward to try and address some of these things. And we'll mix it up a little bit this time because we went that way, we came back this way. So I'm going to throw it to Mr. Rodas to go first.
Thank you. I believe that we need to think of a short-term and a long-term approach to addressing this. With a GDP at 17%, moving to 20% in no time, I think that we have to come up with some immediate solutions. I think that the new norm for improving our healthcare system from a health IT standpoint is going to happen over time. The train is moving, and I don't think it's going to stop. Just to give you an example, coming from the College of Medicine at UCF, 90% of the classroom training that our medical students are receiving with the new medical school that we built 3 years ago, it's all done by computers and interactive technology and virtual technology. We have a virtual family that these people are learning to work with to become medical professionals. So I think that that's the new norm. It is going to happen over time. But I think in the short term, what we need to do is we need to use a carrot and a stick approach to incentivizing our healthcare providers and stakeholders to get things done. I believe that incentive programs coming from the federal government, the state, Florida as well, some of the local organizations is very helpful, especially for providers in rural communities that are having significant financial strains to make the investments to adopt technology. But I also think that other stakeholders are going to have to play a role in this. Health plans, employers, I think, play a critical role. They have a vested interest in keeping our people healthy. I would much rather see someone being treated at a clinic, being managed well as it relates to chronic conditions, than having that person ending up at a hospital's emergency department and later on ending up with an amputation of the legs because they are not getting the preventive care that they need. I think that we need to embrace patient-centered medical homes. I think that it captures the essence of where healthcare transformation is taking us into the future, but it's going to take some investment.
Okay. Thank you very much. Mr. Young.
I think from our practical problems that we run into from day to day, a combination of policy support and consistent law and regulation would really, really be helpful to us and helpful to the citizens of Florida as well as any state. Especially along Medicaid lines, clear definitions and clear understanding of telemedicine and how it's delivered and what it does helps with Medicaid. I will point out as we go from state to state, we find that states sometimes do get something right, say, in Medicaid, but forget to go to the insurance code and get the insurance code lined up with what they want to try to accomplish with Medicaid, because if they want to get telemedicine done, the private insurers are also going to want to get involved in it. And so getting that kind of consistency across the policy, legal, regulation area and state law and regulation. And of course, at the federal level, Representative Mike Thompson has introduced a bill, sort of a leveling bill, that is trying to get some consistency from the CMS side of that, so that Medicaid agencies and states can develop regulation that are consistent along those lines. We're never saying that every state should be the same as the next state, because that just simply doesn't work, state-to-state populations. But developing some sort of core policy understanding. A lot of states often tell us one of the reasons they resist telemedicine is that the increased access will increase cost, which is a problem that you deal with every day. We think that may be a bit of a false premise. It seems logical, of course, that more access, more people use the system, the cost will go up. But we know in behavioral health that the not getting access to behavioral health early increase long-term costs. It also increases medical costs, and there's many studies that verify that. So if we could get a good look at that cost-benefit structure of the delivery of telemedicine through Medicaid and Medicare, we think that folks would really move along because they know that they could reduce their long-term cost.
Okay, excellent. And for the audience sake, it is in Florida we have some limited use of telehealth services through Children's Medical Services and through some telepsychiatric services as well for consultations and things like that for not only kids but moving into the adult population. We started that initiative back in around 2006, where we started with the CMS population in some limited rural counties, and now have expanded that a bit more. Next, Chris Day, your thought.
So maybe three things. First is thinking about we have lessons that we've learned within the state and then outside, and thinking about how do we appropriately scale the things that work and be nimble on the things that matter. And so what I mean is, throughout the state, there are glowing examples of where you've been able to have interdisciplinary care teams supported by technology actually improve access, provide 24-hour support, access to a primary care physician, and other things. And so looking at, even within Aetna, we're a big company, and when you're in a big company, it takes a long time to get everyone lined up through our standard process to get a decision made on the things that matter and what we know works. But when you get something that works and you can align it up and scale it, and an example of in the first year that we actually facilitated the development, actually working with Blue Cross Blue Shield of North Carolina, as well as the state of North Carolina employee population, we facilitated the development statewide of use of health information exchange, clinical decision support technology, and alignment of plan design and patient-centered medical homes, and in the first year saved the employee plan $170 million. The idea, though, is first we started with a specific population that had an affordability challenge and an access challenge. We took some concepts from what we've all talked about today. How do you improve access to clinical decision support and have actionable information in the physician office to improve care? And how do you work in a patient-centered medical home so you have physician-directed coordinated care? So taking those things and then having a nimble process to provide block grants and around enabling local innovation to build on what's available, I think will help us be in a good position to scale something statewide that we know works and most efficiently maximize the use of the resources that we have today for healthcare.
Excellent, thank you. Dr. Nair.
Sure. So, I'm not a policy expert, but I am a medical expert. And what I would say to policymakers is, the worst place to treat a patient is the emergency room. And the best place to treat a patient is in the comfort of their own home or their own community and their own environment. which also, by the way, is where they experience most of their disease, whether it's diabetes, hypertension, et cetera. They're certainly not in my office the most of the year, hopefully, if I'm doing a good job. And so I think it's about enabling policies that help the end users, like the patient and the providers, do their job better. And while I think the carrot and stick mentality is helping us with EMR adoption, it's sort of forcing docs and forcing provider organizations and payers and so forth to say, you got to do this stuff is expensive, use the technology. But I think to the extent that we're developing policies that are done with the provider and patient population instead of being done to the patient and provider population, and to the extent that we are saying, telehealth, remote patient monitoring, these are solutions that make sense to bring down costs and improve quality in healthcare. So we will work out the liability issues. So we will work out the reimbursement issues. Fundamentally, if providers are concerned about malpractice, if they're concerned about security, if they're concerned that they won't get reimbursed, it becomes an end user issue. And I think that we have to continue to piggyback of federal legislation that's clearly saying, technology is an enabler, but to take it to the next level, we really need to have that happen.
Okay, very good. We're going to go to questions from the audience here in just a moment, but I do have one question. In 2011, the Florida legislature passed the largest single reform program of our Medicaid program since its inception. And one of the concepts surrounding that was to divide the state into regions and trying to tie urbanized communities to rural communities. Mm-hmm. And when health plans would be to bidding in the process of getting one of those regions, they're going to have to provide adequate network capacity, even in those rural communities, to try and drive access to care. How do you see, or is there a way that a health plan can build that network, can have the network adequacy, can have the ample number of specialists in our rural communities without doing more additional telemedicine? Would anybody like to weigh in on that? Not all at one time?
Well,
pace yourself.
Well, Representative, I have a bias towards the telemedicine part of this sort of thing. So as soon as I hear something like that, I start calculating workflow in my mind about how I could get those urban specialists through video technology serving those clients in the rural community. It's premature to say this, that we have enough bandwidth, but bandwidth issues are moving rapidly towards a solution. We see that all over the country, even in the Southwest, with very rural desert country. So I think we're getting there eventually. I think the next part of the process is our implementation, our general acceptance that we've talked about here by the professional side of the equation as well as consumer, and then the implementation of these projects. But from my perspective, that bias is there, and I would say, I'll enhance your telemedicine network by doing that. It's especially interesting that you take the rural-urban match like that, because that lends itself very well to using a telemedicine approach to reach the folks in the rural communities.
Maybe why we did it. Just throwing that out there.
I could give you one example of specific to Medicaid and also specific to high cost is the use of specialty children's clinics or specialty children's hospitals, and that is we've started working on the first pediatric ACOs or accountable care organizations with the intent of saying, I come from a family of doctors, so I just kind of talk doctor speak sometimes, but it's always easy to say, you have this kind of patient that has a bunch of different needs, and it's easier for me to just call and send them. Playing my dad now for a second. It's easy for me to just call them and send them to Children's or into the university than for me to manage them locally. As soon as you send somebody that could have been managed locally and would have been better suited to be managed locally and in the community versus actually going into an urban environment, you have to pay for travel, you have to pay for the lost work, you also for the family who's taking their child in, and then you're paying for a higher cost service potentially when it wasn't necessary. So there's opportunities where you have to align. Part of that's around aligning technology between the two. How can the university or the children's hospitals physicians reach out and support the individual in the community? How do you align incentive, so both payment or plan design, so that the individual and their family can access services in this way, so that the physician who is now working with a university physician in an urban environment can interact and get the support they need and still maintain that individual's health in the specific community. So it's an alignment of incentives, plan design, technology, and it's a partnership between typically public institutions and rural communities, where today it's always easier to pick up the phone and send somebody else out because your practice is full and this looks like something I can't handle. But if you actually have access to it and it's incented and it's part of something that you can now manage and have support, things will get done in the local community, and you can better use the resources that you have.
Well, thank you very much. I want to thank the panel for your insights. I want to thank the audience for your very thoughtful questions. And if you would, please give my panel a nice round of applause.